All right, good morning. Thank you for logging in and participating in our case reviews for April. We have some good examples of excellent care and some examples of where we can do better in the next 4 cases. Well, without further ado, we'll start so that we can move on with our day. So once again, these cases are our cases that our Clark County EMS crews have gone on, so they're protected and privileged information. If shared, it's at risk of litigation, so please be respectful for the patient's information and course. So case 1 is a case of a 70-year-old female. Her chief complaint was choking. PPE use was appropriate for the situation. She was found to be awake. Her airway was open, but she appeared to be labored. She had a pulse that was present and no evidence of any active bleeding. Vital signs were obtained shortly after patient contact, notable for heart rate of 153, hypertension at 183 over 123, or respiratory rate of 30, a GCS of 15, and room air sats of 96%. She was an average-sized woman. Her past medical history includes vocal cord paralysis. She's had a previous stroke with right-sided deficits. She's also had a PE, and she has a history of seizures. The story that was relayed to EMS upon arrival was that she was eating dinner when she appeared to start choking. She is bedbound, she does not get up, and that they were unable to perform a Heimlich maneuver, or for those that are up with the newest terminology, an abdominal thrust, because of the position that she was in, I believe. The family relayed that she's been intubated 9 times previously and that she has had a history of difficult intubations. Vital signs, again, are the ones that I had presented to you guys in the previous slide. 5 minutes into her encounter, a non-rebreather mask was placed. Attempts at abdominal thrusts were made by EMS, and that because she had some air movement as well as stridor, they suspected maybe a partial airway obstruction. An IV was placed, and she was initiated for transport 11 minutes after patient contact. Subsequent vital sign shows continued tachycardia, improvement in her blood pressure, and stillness tachypnea at 30 with a SAT of 100% on a non-rebreather mask. And she arrived to Legacy Salmon Creek about 22 minutes after initial patient contact. So a lot of these cases are a little bit presented a little bit different because they are follow-up from Dr. Mock. But the QA discussion was that there was great decision-making on the part of the crew to not intubate this patient. Vocal cord dysfunction does not require intubation, and it can be harmful. It can be difficult to diagnose a difficult diagnosis to make, but with this patient and the extensive history, that was a little bit easier. So for follow-up on this patient, the emergency room doctor was being cautious, and they intubated her. She was extubated on the subsequent hospital day, and she's doing well. She's following up with ENT and speech pathology, which leads us to talk about some information about vocal cord dysfunction. So vocal cord dysfunction is diagnosed, or is a diagnosis for when the vocal cords do not open correctly. The vocal cord muscles may tighten, and that the triggers can be similar to asthma. So this may present or be mistaken for asthma. So upper respiratory illness, postnasal drip, cold exposure, acid reflux, all the things that might typically trigger asthma. The symptoms may sound or seem similar as well. Patients will be short of breath, they might have coughing, they might have wheezing, they might be hoarse, there might be changes in their voice, and they may have throat tightness complaints. The mainstay is that the act of breathing in is much more difficult for vocal cord dysfunction patients than breathing out, as you would expect with reactive airway disease such as asthma. So again, a diagnosis that can be mistaken for asthma. The diagnosis for vocal cord dysfunction requires lung function testing, and that's like your spirometry. Oftentimes, these patients will go and get a lung function test and have a normal lung function test because the vocal cord dysfunction is intermittent. So that's a key to identifying potentially this diagnosis, as well as laryngoscopy to be done at the same time as the patient's symptoms to see the vocal cords acting erratically. And then treatment is to relax the throat muscles. In the event that you have a contact with a patient with vocal cord dysfunction, this is probably going to be a diagnosis that has been previously identified and that the patient presents with shortness of breath and somebody on scene saying they have a vocal cord dysfunction. So activities that may relax throat muscles. Interestingly enough, this last Sunday, we had a 17-year-old who came in to Peace Health with shortness of breath and stat placed with a history of vocal cord dysfunction and intubated 20 times in the past. And I pulled up some of the information for what is suggested in the event that we felt that she was having another episode, which is the following. When you begin to feel tightness or noisy breathing, such as stridor, use these strategies. Relax your shoulders, never pull or push in the breath. Breathe in deeply through your nose and blow out through pursed lips. Drink water at the first sign of symptoms. Breathe using a tongue roll, placing tip of the tongue behind the bottom teeth or lip and stick bulk of tongue out. Breathe deeply. Alternate nostril breathing to relax throat and breathing. If this happens during exercise, stop the activity and use the above breathing techniques, as well as breathing in and out of the front of your mouth as if breathing through a straw. And then if with walking or easy exercise, place the tongue up behind the upper teeth and inhale through the nose and gently out through the front of the mouth. So many suggestions on how they can work on their breathing to relax their throat muscles. I didn't put them in the PowerPoint slide themselves. If you do find objective findings such as wheezing or stridor, you may want to try the rescue meds that we have, such as bronchodilators, or maybe even a trial of racemic epi, but only if you're finding objective findings on your exam. If you do move forward to intubating somebody that you believe has vocal cord dysfunction or you're concerned that they have a history of, the recommendation is that you don't use an ET tube. You use an iGel or an LMA to try to preserve or decrease the chances for vocal cord stenosis or scarring. So something that allows you to ventilate them without placing another ET tube through. And then I have the asterisk here to remind me to tell you that in the emergency room, we might be able to perform laryngoscopy while they're awake to evaluate if their vocal cords are acting inappropriately or if there's any evidence of swelling or other pathology that's leading to their shortness of breath. And oftentimes when we are looking with endoscope, we have a ET tube loaded on that. So if we see anything abnormal, we just pass the tube. So a little about our Southwest protocols. I brought up the airway management overview procedure, and really this is pretty straightforward, or should be pretty straightforward for us as something that we assess on every single patient, even if their chief complaint isn't shortness of breath, but to make sure we don't have to approach it or address it. So airway control and protection is when we're moving forward with this, and any evidence of inadequate ventilation or oxygenation, placing supplemental oxygen in one form or another, and then considering an adjunct if necessary, maybe doing non-invasive ventilation through a BVM or CPAP, and then making sure that we use N-tidal for all intubated patients in consideration for PEEP with COPD or heart failure patients. Any questions about case 1? I believe not, so we'll move on to case 2. So case 2 is a case of a 76-year-old male who was sitting in a chair. I believe the narrative said at the top of the stairs or maybe in a bedroom, but so the chief complaint was that the patient had a fainting episode. PPE usage was appropriate for the situation. Primary survey is that the patient's awake. His airway is open. He's protecting it. He appears extremely pale with no evidence of any active bleeding, and vital signs were obtained shortly after. Patient contact, heart rate 90, blood pressure 104/76, respiratory rate of 16, GCS of 15, and maybe a little on the thinner side, but 70 kilos. His past medical history included a stroke, no documentation of any residual deficits, and that the patient was found slumped forward in a chair. He had a Syncope episode while he was in the bathroom, leading to a fall. He reported that he was weak earlier in the day and that 2 weeks ago he had fallen and suffered an injury, but never had sought medical evaluation in the interim. So it's documented that right upon patient contact, a 12-lead EKG was obtained, which showed sinus rhythm, normal axis, normal intervals, and no evidence of ST abnormalities, normal R wave progression. So all in all, normal looking. Vital signs were obtained. An IV ×2 was placed. He received approximately 1 liter of fluid, and his blood glucose was checked. And then after receiving 1 liter of fluid, an attempt for orthostatic vital signs were made. The patient was profoundly hypotensive despite the fluids, with a blood pressure of 83/48. I believe, it's not documented, but I would imagine that with those vital signs, I sat him back down. They checked another set of vital signs about 5 minutes after the orthostatic attempt, noted to still be not tachycardic at a rate of 74, blood pressure improved of 95/59, 16 for respers, and normal mentation. Because of his previous injury 2 weeks ago, he had some neck and back pain, so he was placed in spinal precautions. He also complained of right hip pain on that exam. In that next set of vital signs at 34 minutes was improved blood pressure at 115/63, and transport was initiated approximately 42 minutes later from patient contact. He received aid of Zofran. His 12 lead was repeated. It was unchanged. His vital signs were repeated, also unchanged, but overall improved. And he arrived at the hospital 63 minutes later at Legacy Santa Cruz. So feedback from Dr. Mock is that we have no protocols that suggest orthostatic vital signs should be obtained. Orthostatic vital signs are well documented to not be useful at best, even in the emergency department, and it's hard to imagine a role for them in pre-hospital care. It's possible that you might be asked to get orthostatic vital signs if you are calling for potentially a refusal, but this is probably going to be very unlikely unless you have somebody that may have trained a long time ago. And it's potentially harmful. So a patient who has a syncope fall and remains hypotensive should remain supine. We should not stand them to walk them. We should not stand them to do vital signs. So he was diagnosed with a ruptured AAA. He was transferred to a manual where he underwent a successful endovascular repair, and he was discharged in good condition, making a full recovery. So I think this is a good opportunity to talk a little bit about orthostatic vital signs. Hopefully none of us on the call are doing orthostatic vital signs in the pre-hospital setting. And I was a little hesitant to even talk about how it's done or interpreted, but I think that at least this slide here can even point out that you may not be taking them or considering taking them correctly. So they recommend lying flat for 3 minutes, sitting up for 1 minute. So lying flat for 3 minutes, taking a set of vital signs. And it's heart rate and blood pressure is specific on how they interpret them as being abnormal. Sitting up for a minute and then taking another set of vital signs, and then standing and measuring an immediate vital sign check and then 3-minute vital sign check. So I think that there's a wide interpretation of how to do orthostatic vital signs, and then there's also equally, if not more so, a wide interpretation of abnormal vital signs. I've heard 10 beats per minute to 20 beats per minute higher and change, heart rate change, anywhere from 30 millimeters of mercury to 20 millimeters of mercury change for blood pressure, anything from that they stand up and they feel orthostatic as being positive to not being positive. So there's so much variation to how they're done and interpreted, which probably speaks to why they are not very useful as a surrogate for volume depletion. In this study, done in 2019, published in the American Journal of Emergency Medicine, talked about orthostatic vital signs. Do they predict badness at 30 days in older patients that have either suffered a syncopal or near syncopal episode? So older patients being older than 60. They looked at 11 academic centers across the United States, and they enrolled, I think that there was 10,000 people eligible, 6,000 remaining that could still stay in the study, and then between loss to follow-up and lack of interest in lack of interest to participate, that it went down to about 3,000 patients that were enrolled. And they looked at primary outcomes as well as secondary outcomes. The primary outcome for badness included any type of cardiac intervention, significant dysrhythmias. These included VTAC, VFib, sinus pauses, long sinus pauses greater than 15 seconds, second degree type 2, third degree block, as well as an MI, structural heart disease, PEs, strokes, intracranial bleeding, internal hemorrhage requiring blood transfusion, so including GI bleed, subarachnoid hemorrhage, aortic dissection, CPR or death, and then recurrent syncope. And the short-term serious events were events that occurred during the emergency room. So serious primary outcomes at 30 days with abnormal orthostatic vital signs was 15.3% of those patients, where they looked at the 30-day serious outcome in patients that had normal orthostatic vital signs documented, and that was 14.7. So they did not identify a clinically significant difference between normal and abnormal orthostatics predicting badness at 30 days. And that the odds ratio of the syncopal, near syncopal episode, meaning that you could, or I should say the exposure of a near syncopal or syncopal episode with orthostatic vital sign abnormalities did not predict with the odds ratio that there was a correlation. So, I want to also mention that I found many more studies that also spoke to the fact that orthostatic vital signs are not useful. That one particular study talked about nursing home patients that, clearly they're not healthy and that they are at a nursing home, but 60% of the nursing home patients that had orthostatic vital signs done and they had no chief complaint were positive orthostatics. In that, I also looked at data at pediatrics and doing orthostatic vital signs, especially in the teenager category, and that was also not a predictor of badness in these patients, and that oftentimes the orthostatic vital signs were positive and there was, as you would expect, no correlation. And of course, physiology in elderly patients or even medications can prohibit normal mechanisms for the body to compensate. So all in all, orthostatic vital signs are a coin flip to how they're going to be useful. They're not something that a lot of credence should be placed in it, and we really should not be doing it in the pre-hospital setting. If our patients have a syncopal episode or near syncopal episode, we really should be getting a set of vital signs and giving them recommendations for transport and addressing when they want to refuse. So this is our protocol. Syncope is a loss of consciousness and postural tone resolving spontaneously without intervention. We talk about that it could be described as fainting. I've also heard it as described as falling out. It's typically abrupt in onset and resolves quickly, and that they Presyncope is a prodromal symptom of feeling like they're going to pass out, and they may describe it as blacking out or nearly fainting. But as you look down into the treatment section for our syncopal protocol, there's no mention of checking orthostatic vital signs. Any questions for the case 2? All right. I have my watch to make sure that I'm doing okay, so I'll just look up there. Okay. All right, so if no questions about case 2, we'll move on to case 3. All right, so case 3 is a 3-year-old female that EMS was dispatched on. The chief complaint that EMS got was not breathing. PPE usage was appropriate for the situation. They arrived to find a 3-year-old female that I believe was in fire's hands, getting a non-rebreather mask. They had arrived on a mill plane in Andressen. I'm probably mispronouncing that. For a child that was being transported by her mom in an effort to get to the hospital. They noted that her airway was open, but she wasn't protecting, and that the report given to our EMS folk was that she had irregular and shallow respirations. Her pulse was present, but she had no active bleeding. Initial vital signs obtained rapidly upon arrival showed a heart rate of 126, a blood pressure of 134 over 87, a respiratory rate of 30, a GCS of 8, an SpO2 of 54%, and I believe that that 54% was room air, and then a weight of 10 kilos. So besides the SpO2, that believing that these vital signs are close to baseline, maybe a little more tachycardic and hypertensive. Past medical history is that the patient has asthma, and that the HPI provided by the mother was that the mom went and picked up this child. I'm not sure if she got picked up from daycare or from some type of event. She noted that her limbs were stiff and that she wasn't responding or breathing normally. Mom loaded her up in the car and started her trek to the hospital and made it to the point until Vancouver police pulled her over for probably running lights or speeding or something along those lines. And once they made contact with the mother and found the patient to be the way she was, EMS was notified. The mom provided additional history that the patient has had a cold, but she hasn't had a fever, and that there's no reported trauma. So after initial patient contact, it's documented as a SGA, but I don't know if an SGA was actually placed, but a bag valve mask was definitely placed and talked about in the narrative. She had a rapid improvement with this assisted ventilation, with her SATs going up to 97%. Her blood glucose was 157 at 8 minutes, and transport was started 5 minutes after patient contact. 8 minutes into this call, 1 milligram of Versed was given through an IV. Yep, I did put it there, sorry. And that her temp was documented as 100. Her end-tidal CO2 was checked at 11 minutes with and this is 11 minutes of assisted ventilations with her end-tidal reading at 87. 22 minutes into this call, Tylenol was given. It was noted that the patient had a left gaze and she had tone, or she was tonic. And then about 15 minutes later, 2 milligram from the initial Versed, 23 minutes into the call, she was given 2 milligrams of Versed. Seizure activity stopped and vital signs were rechecked. She was suctioned as she had some secretions, and she arrived to the hospital at 28 minutes with a normal or a markedly improved SpO2 and downtrending end-tidal CO2. So this patient had gone to Legacy Salmon Creek, I believe, and the feedback was great documentation, great care. So the patient was admitted for 2 days, hospital day 1 and 2. Her final diagnosis was status epilepticus. Her secondary diagnosis was viral URI. She had a CT scan that was unremarkable. She had an MRI that was unremarkable, presumably MRI of her brain. And then she received anti-epileptics through the form of Keppra. She had no focal deficits, and they thought that her seizure disorder or her seizure presentation was consistent with a complex febrile seizure. She was discharged home without continued anti-epileptic therapies.
Jackie, this where was she picked up? Where was she found? Where was the
documented Millplain and Andresen? I don't know how to say it.
Why did she go to Legacy Salmon Creek? That's a half a mile from Peace Health.
I think that might be a question for the crew. I don't know. They didn't document, and I guess another example of that I'm new to the area. I didn't know it was a half a mile.
Yeah, well, Mill Plain runs across right in front of Peace Health, and Andresen is 2 stoplights down.
Yeah, I know where Millplain is because I map it. And now I actually don't need to map it. I can get there without. But yeah, I don't know, and that's a good question. I don't know.
I'm sure that's probably the request of the mother, but why was she driving erratically close to Peace Health Southwest if she got stopped by the police there? And then it seems to me that's an extra. I mean, that would take an extra 15 minutes to get to Salmon Creek.
Yeah, I'm not sure. Maybe she was driving erratically to get away from the Peace Health force field. I'm just kidding. I don't know. I don't know why, but that would
we need to query the crew on that one. I mean, I'm sure it's the patient. It doesn't seem reasonable to travel an extra 15 minutes when you have a kid who's in a who's in quite
extremis.
In extremis at that point. Also, you've got a it's probably a little under. If it was nice that they picked up that this was a seizure. It's probably would have gotten better with 2 milligrams of Versed to start with. 0.2 per kilo.
If they didn't have an IV. But yeah, because that was one of the feedback points.
They ended up giving 2 doses of Versed, which was appropriate because it didn't stop with the first one. But then they gave a higher dose the second time, which was the appropriate dose.
At least not in our protocol, but yeah.
Oh.
Yeah, so I don't know why she had gone. This little girl went to Salmon Creek, but she did, and she got transferred. I don't think I wrote it in here, or at least she got transferred to Randall's.
Sure. Yeah. Wish she got transferred to Randall anyway, but
yeah.
Yeah.
So I thought this would be another good case to review what we know about febrile seizures. We don't know a lot about the pathophysiology, but we do know a couple of things. So it occurs when there's a spike in a temperature above 38 degrees Celsius. And the reason why I say 38 degrees Celsius is that each child has a different threshold to have a seizure related to a fever. So you can't say that it's a certain number. So it's dependent on each individual patient. There's a vast variation on what they consider the age range. So I think the general consensus is that it's 6 months to 60 months, which is 6 months to 5 years old. And that in this age range between 6 months and 60 is that 4% of the children will end up developing a febrile seizure. And the pathophysiology is not well understood. Some people have talked about, at least when I've been reading about this over the last 15 years, wondering why they're having a seizure in regards to a fever and why adults don't do it. It's some type of response to try to cool down the body by having a seizure is what I've read in the past. But in this particular article from National Institute of Health, they said it wasn't understood well, and that we do know there's a genetic predisposition, meaning that a first-degree relative that has a first-degree relative of a kid who's had a febrile seizure has a 10 to 20% risk of having a febrile seizure as well when they're sick. And that it's further categorized by the type of seizure, either simple or complex, and that simple is the most common one that we'll see, where they'll have generalized seizure activity, tonic-clonic, less than 15 minutes, and they don't have another one for in the next 24 hours. Where complex is that they have focality. It may not be generalized tonic-clonic, and that it lasts for greater than 15 minutes, and they might have another one within that 24-hour period. So any of those three make it a complex seizure. This kid had 2, greater than 15 minutes, and multiple. So status febrile seizures is any that last for greater than 30 minutes, and that that is a rare incidence, with less than 10% of febrile seizures meeting the criteria for status. And that 30% of febrile seizure patients will go on to have another status seizure in the future. Let me see if there's anything else. Oh, a couple more things that I wanted to talk about is that with febrile seizures, they're usually, especially with our simple ones, they're usually brief and they have a rapid return to baseline, either that they are responsive and crying, or that they are actually back to their baseline. And if we find that they're absolutely unresponsive, that should heighten your awareness that this may not be a typical simple febrile seizure, or that this might be some other pathology that's going on. And yeah, that's all I had for that. So this is our protocol. If the pediatric patient is in status, the recommendation that we have is that it's 0.2 milligrams per kilogram intranasal, with the option to do 0.3 mg per kg IM. And that if an IV is placed, it's 0.1 mg per kg IV or IO, with a max of 5 milligrams repeated every 5 minutes. So this kid appropriately was given 1 milligram. She is a 10 kilogram patient, so 1 milligram was appropriate. The subsequent dose of 2 milligrams is not based off of or guided by our protocol. So Dr. Whitwer is the decision maker for our protocol. So as you heard, he was I don't know. Do you change your stance on doubling the concentration for the subsequent dose?
No.
Okay. So there's that. And then the other thing is that this kid was given Tylenol, and I'm sure it's the formulary that we have, but the Tylenol dose I think was 240 milligrams, and for this kid it should have been 150 milligrams. So it might just be the formulary that we have to give it. So I don't know if we have the ability to adjust the amount of Tylenol that we're giving if we're doing it weight-based. But the other thing is that the Tylenol, according to our protocol, should not be given unless it's greater than 103 degrees. So I don't know how strongly you feel about that, Dr. Whitwer.
Well, I don't feel strongly about it, but it certainly wasn't necessary. They documented a fever of 100, which is not the reason this kid was seizing at that point. Its fever was already coming down, so the old story is it's not how high the fever is, it's how fast it goes high.
Yeah, and that's what the same what I found in the 2021 review.
Right.
All right.
The acetaminophen by suppository form at 20 mg per kilo is perfectly okay because acetaminophen isn't terribly well absorbed rectally. So I mean, it absorbed. You're never really 100% sure. Let's but it was just an add-on. It was something to do.
Yeah, that's no problem. Yeah, and then the normal dosing for oral for any of those that are listening that don't know is 15 mg per kg. So 20 is just a little bit more, and it's the overall amount of ingestion in 24 hours. So you're not overdosing this kid. All right, moving on to case 4. If there's no questions, we're just going to get done early, actually. All right, so EMS was dispatched to a 56-year-old female, not Christy Alley, but that's the only picture I could get that I felt like was somewhat reminiscent of the patient, just being older and heavy. So she complained about weakness and a cough. PPE usage was appropriate for the situation. Primary survey is that this patient is awake. She had an open and protecting airway. Pulse was present, and there was no evidence of active bleeding. Her vital signs, I debated even putting them up here because they were obtained 24 minutes after patient contact, which kind of takes it out of the primary survey, but I put it up here anyway. So heart rate of 113, blood pressure 135 over 95, respiratory rate of 24, GCS of 15, temp of 98.9. It's documented that her weight's 113 kilos, but her weight was actually 145 kilos. She was 5'2", 325 pounds. Past medical history includes chronic pain, and the story that EMS was given was that EMS arrived to find the patient on the floor with her family around her, and that she had said she had fallen because her legs had given out, and that the family couldn't get her up off the ground, so they were asking for EMS to help lift her, and that the patient had told EMS that she had chronic nerve pain in her lower back, and that, oh, by the way, I was seen a week ago, and they told me I had fluid in my lungs. They tested me for COVID. I didn't have it, and they sent me home. So the set of vital signs obtained were at the time of transport. I believe the interim time between the 0 minutes and 24 minutes was related to waiting for fire to arrive and for the patient to be extricated out of the bedroom and out of the house. Another set of vital signs were obtained at 32 minutes. She was still tachycardic, a little more hypertensive at 155 over 102, still tachypnic. She arrived at the hospital at 38 minutes after patient contact. So hindsight's always 20/20. I'm fully aware of that, but I do think even knowing that her outcome, the feedback I could provide is that ensure you're investigating abnormal vital signs thoroughly. So with this patient who had mentioned something going on with her lungs and also complaining of shortness of breath and this weakness that she relates to causing her to collapse, to consider or to obtain at least an SpO2. The crews did document clear breath sounds, which was present upon her arrival. Her lungs were clear sounding. Obtain a 12 lead. This is a patient that short of breath, who's in her 50s, who by evidence on exam is not the healthiest, and when asking her, she doesn't have a PCP, she doesn't get annual exams, so getting a 12 lead to evaluate if there might be some reason for why she is short of breath, and then maybe getting an end-tidal CO2 to see if she might be hyperventilating, and then the importance of a good exam, a thorough exam. Our morbidly obese patients make it difficult to do a good exam, but it doesn't mean that we shouldn't make every effort to do one. And then just the diagnosis or the condition of morbid obesity puts them at higher risk for pathology, acuity, badness, and that our index of suspicion needs to be high with a wide differential diagnosis. So in the emergency room, she complained of shortness of breath, a dry cough, fluid retention, leg swelling, and weakness. She did mention that she had some upper back pain, but said that that was chronic for her and that she was seeing a chiropractor as well and doing some medical management for her back pain. She kind of minimized her back pain substantially. She physical exam is that she was very orthopnic. She couldn't tolerate even semifowlers. Her breath sounds were clear to auscultation. She was tachycardic. I did not hear any murmurs. And when we laid her down just a little bit in order to facilitate a posterior exam and to evaluate her spine, she reported no midline tenderness to her spine. She did have 1+ pitting edema, bilateral lower extremities, and she had movement and sensation in all 4 extremities. We knew she was tachycardic and tachypnic based off of pre-hospital vital signs, but we were surprised or weren't anticipating a temp of 38.1. In combination with that, her symptoms and the rest of her vital signs, she was upgraded to a sepsis alert within, I'd say, 5 to 10 minutes of her arrival. She was worked up for possible pulmonary cardiac infectious issues and found to have an unstable T5, T6 fracture with retropulsion, meaning that the fracture was pushing into her spinal cord. And by the time that the neurosurgeons came down to evaluate her, she no longer had sensation or motor of her lower extremities. So she was essentially paralyzed. Based off of the CT scan as well as her new neurological deficits, the plan was to get a stat MRI of her spine, knowing that she couldn't tolerate even semifowlers and needing to lay flat for the MRI, and then also the belief that she would be going to the operating room. She was intubated, which was potentially going to be difficult given her BMI of 55, but it was not extremely difficult. And then intubating her with inline spinal precautions. She went to the operating room. They did a laminectomy of her T4 through T6 vertebrae and allowed for decompression of her spinal cord. They found an epidural abscess associated with it. Her blood cultures that she had in the emergency room, 4 of them came back positive for Staph aureus, methicillin resistant. And during her overnight stay on hospital day 1, she was hypotensive, requiring pressors. She was extubated on hospital day 2. She still is complaining of shortness of breath. She does have sensation. She has regained sensation in her legs. She has a little bit of movement in her lower extremities. They don't know why she had what appears to be unknown source for her epidural abscess, discitis, osteomyelitis. Trying to think of anything else I should report. They did an echocardiogram yesterday, and it was limited by her body habitus, but they noted her EF was 65. They didn't see anything abnormal with her valves, but again, technically difficult because of her body habitus. So, vertebral osteomyelitis. Median age for this to occur is between the 50 and 60-year-old age group, and the most common site is going to be the lumbar spine, up to 50 to 60%. The next most common is going to be the thoracic spine, about 30 to 40%, and then the cervical spine is like about 10% of the time. The risk factors for this to occur is going to be anybody that's an IV drug user, a diabetic, recent systemic infections such as urinary tract infection or pneumonia. They're immunosuppressed, such as like HIV or organ transplant. They have a history of malignancy. They're malnourished, they're obese, they suffer trauma, or they're a smoker. For her instance, it was her risk factors included obesity and smoking. The pathogens responsible for this are going to be bacterial, potentially fungal or TB, in that approximately 20%, up to 20% of these patients that have vertebral osteomyelitis may have some type of neurological deficit, but if they have an associated epidural abscess, that goes up to 50%. The presentation is going to be either a history of a urinary tract infection, pneumonia, skin infection, organ transplant. A third of these patients will have no fever. The pain that they describe is going to be severe or insidious, kind of gradually getting worse. Usually the pain is worse with activity, and that the pain awakens them at night. Their neurological deficits can be like a radiculopathy or a myelopathy. A little bit of an explanation between the difference of those two is that myelopathy is when the spinal cord's compressed and they either have a loss of sensation or function, or they have pain or discomfort in the area that the spinal cord is being compressed. And then radiculopathy is going to be like a pinched nerve coming off from like a spinal nerve root. So that's like that pain zingers down their leg. The diagnosis of this condition can be potentially picked up by X-ray, but CT and MRI are going to be the mainstay. The image on the left is an X-ray, and what I'd like to point out to you, not that you're going to necessarily be reading these, but oftentimes us ER docs like to show you abnormals, and that you can cue in on what you're looking for. So this X-ray of a thoraco spine shows the loss of what they describe as owl eyes. So these represent the pedicles, and you see that there's no owl eyes or pedicles because the transverse process is supposed to be the beak. So there's no facets or pedicles, pedicles present on this X-ray. The image on the right is an MRI showing that the superior and inferior end plate is obliterated. In the other studies that can be used to identify this condition is blood cultures, labs, inflammatory markers, and then biopsy. The treatment is initially broad coverage, and then once the pathogen has been identified either by biopsy or blood culture or both, then they can narrow down the antibiotics to appropriate narrow coverage, and that the antibiotic course is going to be up to 6 weeks in duration. And then depending on pain and neurological deficits, they might undergo bracing surgically. So this patient, we don't have a back pain protocol, and with her chief complaint, and we don't need a back pain protocol, I should mention, but querying our protocols, the chief complaint of respiratory distress is where she would fall under, and using that as a guideline, she actually didn't meet any of the criteria to move towards any type of treatment specifically about her shortness of breath, but utilizing universal patient care protocol and airway management and consideration for cardiac dysrhythmia with a 12 lead would be appropriate. All right, any questions about case 4? All righty, so.
It does.
Yeah,
it does strike me that a whole lot of vitals and evaluation could have been done in the 20-some minutes waiting for assistance to transport a patient. If they needed help doing CPR, they wouldn't have waited 20-some minutes for someone to show up.
Yeah.
No, and I just have two comments, one on this case and then one I was able to get some additional information on the previous case. So I just want to emphasize how sneaky these back infections can be. I very nearly missed one last week in someone who didn't have a history of diabetes. He didn't have a history of diabetes because he never went to the doctor, and that was his only risk factor. So just especially if you have the history of diabetes, history of IV drug abuse, any history of fever, those are really, really dangerous patients to leave at home. And then just going back to the previous case, I was following up on that case. The patient was transported directly to Randall.
Okay.
I do think it's a valid point. I mean, you're very close to Peace Health, and stabilizing that patient at Peace Health is completely reasonable. But that patient did go directly code 3 to Randall.
Okay.
Apologize for misunderstanding the.
That explains. That would have been. I should have asked where the what the hospital destination was, because it said, you said legacy, but it didn't say, but it must have been the thing. Which legacy?
Yeah. And I think that I didn't personally go through the chart.
That's not within the strictly speaking, that is not within the protocol that they would have been transported to Legacy. I'm sure, or Legacy Randall, I'm sure that the mother was, that explains why the mother was going, she was probably trying to drive to Legacy Randall, but that would have been a call to medical control, because if that patient was transported still unstable with a destination that was going to be, this is not a trauma, so this is not an automatic pediatric trauma transfer. This would have been a closest hospital kind of destination. Normally we take, I mean, both like Legacy, Salmon Creek, and Peace Health take sick, seizing kids all the time. So
No, agreed.
Yeah.
All right. So to review, with vocal cord dysfunction, it's going to be really important if you suspect that this is the etiology for your patient's presentation, that you're working to try to coach them to improve their breathing through any of those measures I mentioned previously, which was like 10 of them. So it's really about getting them to break their vocal cord spasm. And then what I forgot to mention is that one of the options that they have in the hospital is for Heliox nebulized.
Right.
I'm
sure that the 16, 17-year-old you mentioned is a patient that's well known to me, that's from the Camas area, and I think it would be worthwhile for, and the Camas crews see her a lot, and it would be worthwhile for them to review those methods that you talked about that can help relieve her symptoms. It's often complicated, but she becomes very anxious ultimately, which is of course understandable.
Yeah, is it a patient that has a reported history of hereditary angioedema?
Yes.
Yeah, then it's the same probably.
Yeah, I mean, she's been seen multiple times by Camas, multiple times at Southwest, and almost never has been intubated. But that's because we become aware of her.
Yeah, and I'd be happy to get in touch with Cliff to share that, or to share it through the MPD, and you guys send it directly. But yeah, so I mean, it's
Cliff is on this. I saw him sign in earlier, so
excellent. And then
thank you.
Yeah, so
sitting right, his name is right next to yours on the list today.
Oh. Yeah, and I was just going to say to make sure that if you really want to be pretty suspicious that it's vocal cord dysfunction, you don't want to be trying to tell somebody who is in heart failure or in anaphylaxis to slow their breathing down and try these maneuvers. So have a pretty good suspicion and support that you think it's vocal cord dysfunction.
Generally speaking, it's a history.
Yes. And second point is that orthostatic vital signs are as good as flipping a coin. If you want to, if you're considering doing orthostatic vital signs, you'd be better off to flip a coin because it's faster than to do the full set, and they're just as non-reliable. With status.
And the real point that you brought up at the very beginning is it is not in our protocol. There's nothing in our protocol that ever says do orthostatics.
Third point is with status seizures, it's usually, or with febrile seizures, it's usually fast. It's usually resolved, returned back to baseline. You want to identify quickly when there's an atypical presentation and treat appropriately. And then lastly, with osteomyelitis, which could be of any bone, but with vertebral osteomyelitis like this case, what might seem like a benign, not that concerning situation, you need to have a higher broadened situational awareness and recognize that what seems safe or seems like not a sick patient actually is at risk of further compromise. All right. Any questions? Thank you guys. I appreciate your guys' time. Feel free to discuss any questions, cases, email, in person, however you like.
Thank you.
Thank you.
Thank you, Dr. Gabois.